the next talk is about protocoling acute abdominal CT. So you'll have been in post for a few months now. So it is about 9 months since you started, and most of your time has been thinking about your physics and anatomy exams. But it's start getting your feet wet with protocoling and reporting acute abdominal CT. I know some of you already done that. So we're going to run through a few specific examples of clinical scenarios, how to protocol those CTs, and why it's important to protocol them in certain ways. But clearly the way you're going to learn this is, through the apprenticeship model and just being there and doing it when you're in the inpatient hub. And when we're thinking about protocoling, really the main thing to think about is timing. It's all about timing. Okay. So with CT in the abdomen, it's all about, are you going to give contrast or not? And really that's a very fairly easy question. We'll go through some examples. The vast majority of the time you will be giving contrast, and then it's all about, well, which phases do I need to acquire? Which time points do I need to get them to scan the patient? Okay. So let's go through the first example, which is 50-year-old male, left-sided colicky abdominal pain and hematuria. Now, with this kind of question, they'll normally request a specific exam, because in mind what they'll have is ureteric colic or renal colic. So they will specifically request a CT KUB on the system. And your job is checking that, okay, well, does that fit? Is the history providing me consistent with something that's suspicious for ureteric colic, and therefore is that an appropriate examination? And in most of the times from ED, yes, it will be, and you just need to go ahead and protocol that as a CT KUB. So what does that mean? So that means that it's going to be a non-contrast study of the abdomen pelvis, a lower dose than a conventional abdomen pelvis, and acquired with the patient lying prone. Okay, so this is a CT KUB study. It's non-contrast. The patient's prone. I flipped the image so the patient looks supine, but look, this is the couch, which is adjacent to the anterior abdominal wall. So this patient's lying prone. And the reason we don't need contrast is because we're looking for the density of a renal, ureteric, or bladder stone, which you can see without intravenous contrast. And the sequela, such as hydronephrosis or ureteric distension or perinephric fat stranding, you can see all of those as well without contrast. Okay, so from the top, I want you to get into the habit, when you scroll, try and look from the top and see, right, hang on, can I detect from the beginning which kidney is abnormal? And if I get to about here, I can already tell that I think the left is the abnormal one, because there's more distension of the pelvic calyceal system on the left than there is on the right. The outer edges of the left kidney are a bit more fuzzy than the right, so there's perinephric fat stranding. And then as you scroll down, the left ureter, which is here, is distended. And hopefully we can track it all the way down to a stone. And this is the reason we do these scans prone, okay? Because by turning the patient prone, this allows us to differentiate whether this stone is free within the urinary bladder or still contained within the distal ureter but just prolapsing into the bladder at the VUJ. And if this patient's stone was free in the bladder, it would be lying here anteriorly because of the effect of gravity. But the fact that it's lying here tells us that this is still within the distal VUJ, so it's within the ureter. So it's about to be pushed down to the bladder, and that patient's left-sided colic should resolve. Okay, so that history was consistent with the type of study they requested, and we go through and do a CT KUB, and it's the right test. Now I'll send you a link to this playlist afterwards you can look at, but I also on here just annotated the path of the ureter, because I think it's really important that you learn when you're looking at these studies what the normal path of the ureter is, because sometimes it can be very tricky to appreciate on a non-contrast CT, particularly when it's non-distended. So if you fix in your mind where you should be looking to follow the ureter, then it's quite useful when you're doing other studies where the ureter is not distended. So you can have a look at this case on Radipedia and bookmark it and have a look at the path of the ureter. So let's talk about the actual, that was a non-contrast CT. So really the main indication is for looking for stones. There is one other one that we're going to come to in a little while. But the vast majority will be contrast enhanced CT. And you have to think about which phases you want. Now here I've listed all the main phases that you'll find described in various textbooks. So we have an early arterial phase, which I put in brackets because we don't really do that one very much, which is a really super early acquisition after the contrast has been injected. Far more common that is what we call arterial is actually this one, the late arterial or corticomedullary phase, which is 30 to 40 seconds, acquired 30 to 40 seconds after the injection. Our most common one is portovenous, 70 to 90 seconds. Then slightly more delayed is a nephrogenic phase, and then excretory. Now these corticomedullary, nephrogenic, excretory relate to phases of enhancement of the kidney. So corticomedullary is when you have the most intense differentiation of the cortex medulla. Nephrogenic is like a far more uniform enhancement of the parenchyma of the kidney. And then by 5 to 10 minutes, the contrast is starting to be excreted into the collecting system and into the renal pelvis. So this is what it looks like essentially. So on a late arterial corticomedullary phase, you've got dense contrast within the aorta and the cortex of the kidneys. Then on the next one, you see that it's more equal within the aorta and the IVC, and now the liver is more homogeneously pacified or enhanced. And then you got more uniform enhancement of the kidney. You get slightly later and you see there's more contrast now within the medullary pyramids and sort of collecting system of the kidneys, not yet coming out not into collecting system, but really the parenchyma. And then on the excretory phases, when it's now starting to be excreted into the collecting system and pooling in the renal pelvis. So we're going to now look at some examples where these are really typical histories, but where we're thinking about portovenous phase, contrast enhanced CT. So these are the typical scenarios that you would use that particular protocol. Okay, so when you're doing it in CRIS, it's single phase and it's portovenous. So 75-year-old male with 2 days of increasing abdominal pain, distension, and now vomiting. And also the other thing is this gives me an opportunity to show you a few different examples of acute abdominal CT as well, just to increase that bit of learning. So we'll go to the top, and this is a contrast enhanced portovenous phase. So how do we know? Because we've got nice uniform smooth enhancement of the liver, we've got enhancement of the parenchyma of the kidneys. Now what you'll notice with these CTs is that if you put lots of them side by side, the renal enhancement, despite the fact that they're all portovenous phase, will be slightly different, despite the fact that the acquisition time might be the same. And that's because very slight changes in patients' cardiac function and cardiac output can influence what the organs look like, because the fact that everyone's physiology is slightly different. So there will be slight variation in the enhancement of the kidneys. Even when you have 5 CTs in a row which are labelled as portovenous, they won't all look the same. We've got a nice smooth enhancement of the spleen, and that's a good way of telling whether it's portovenous or not, because with arterial phase, the spleen has got this kind of zebra stripe pattern because of the structure of the spleen. So if we scroll down, then what we see is lots and lots of dilated loops of small bowel, and the transition point is down here on the right side. So we've got this bowel which is coming in, and then it's very tightly pinched in this region. So you have to decide whether or not this is obstruction. So yes, it is obstruction. Are there any what's the cause of obstruction? Well, it's a right groin hernia. And are there any complications of obstruction, such as perforation or mesenteric free fluid? Well, there aren't, but this looks like a fairly high grade obstruction. You also should try and figure out whether or not this is an inguinal or femoral hernia, and this is in fact a femoral hernia. The way to tell that is because you've got the hernia sac is lying on this muscle here, and can you see how it's flattening the lateral edge of the femoral vessel? So there is mass effect in the femoral space, which leads to some compression of the femoral vein. Okay, and if you look at the coronal views, then the direction of travel of the hernia sac in relation to the inguinal canal is also quite helpful to tell you whether or not this is femoral or inguinal. Okay, so another example where you would go for a standard single phase post-contrast portal venous phase study. 80-year-old male, left lower quadrant pain, fever, raised inflammatory markers. So again, we see a nice uniform enhancement of the spleen and liver and the kidneys as well. And this time, the symptoms again do localize to where they've told us left lower quadrant, where you've got quite marked sigmoid diverticular disease. Okay, so all of these gas bubbles here, these are diverticular, arising from the surface of the sigmoid colon. And then at the back here, this is a gas and fluid containing collection. Okay, so as a result of a perforation of sigmoid diverticulitis. There's also fat stranding in this region, thickening of the peritoneal planes. So this is acute sigmoid diverticulitis complicated by perforation. Now, one of the uses of intravenous contrast is when you have a collection as opposed to free fluid, a collection becomes organized and its margins start to enhance with contrast. And so that can be a helpful way of being able to differentiate free fluid from collections. And in the context of peritoneal inflammation, contrast also helps you to pick up subtle peritoneal thickening and enhancement, which is a good radiologic sign of peritonitis. Okay, next one. 85-year-old female, sudden onset left side abdominal pain and bloody diarrhea. Now, a lot of these, the histories are absolute giveaways. Okay, so that first one was a giveaway for obstruction, bowel obstruction. The last one, sigmoid diverticulitis. For me, this one is a giveaway for ischemic colitis. But of course, please don't be led by bias from what the history is leading you towards. So again, portal venous phase, smooth, uniform liver enhancement, putting aside biliary dilatation, smooth splenic enhancement. And then this time we've got an abnormality of the colon. So this is the distal transverse colon, which is normal. Then we head up towards the splenic flexure where it starts to become abnormal. So what's the abnormality? Well, it's thick-walled. There is reduced density of the bowel wall compared to the other parts of the colon. The lumen appears quite closed and the wall is thickened, as I've said. There's not much fat stranding around it. There's no free fluid. There's no lymphadenopathy. And it extends to the sigmoid and then it becomes normal. So that distribution is important. And that's absolutely typical of ischemic colitis. Border zone territory ischemia. So from the distal part of the transverse colon down to the junction of the descending and sigmoid or partway along the sigmoid. Wall thickening, low density, and the typical clinical history of sudden onset pain and bloody diarrhea. Now, with this, you only need a single phase CT. You do not need an arterial phase study in this situation because the majority of these will not be caused by an a proximal arterial occlusion. This is a border zone territory phenomenon, so it's really related to episodes of hypotension or hypovolemia rather than a filling defect. Okay, now let's go to this one. So 30-year-old male, known complicated acute pancreatitis. Okay, so that's important. They're already known and under follow-up for pancreatitis, and this is a follow-up study. And this is just an arterial phase study because I couldn't find a great example which we had multiple phases to show this particular example. So we've got all this stuff which is stents and drainage catheters in the stomach, and then this metallic density device which is basically bridging between a large collection or pseudocyst, which is here with all this gas and fluid and debris within, and the stomach. So this is a gastrocystostomy, and there are stents which are traversing the gastrocystostomy to enable drainage. So the idea of this is that all this gunk can drain out into the stomach. Okay, so this is one of the treatments for a pseudocyst. Now, also note here on this arterial phase study, this little nubbin arising from the splenic artery. This is a pseudoaneurysm. Okay, So because of chronic inflammation of the anterior wall of the splenic artery by this pseudoaneurysm, by this pseudocyst, we've developed a pseudoaneurysm of the splenic artery, and that's quite important to get that treated, or at least know about it, because if that ruptures, then that could be catastrophic. So here it is on an angio. So we have the contrast. This is the pseudoaneurysm. These are all the different bits of tubing and the stents and stuff that I showed you on the CT. And then they have successfully embolized proximal and distal to exclude that pseudoaneurysm. Now, when you're protocoling studies for pancreatitis, if it's the first one, then a standard portal venous phase study will do. But for the subsequent follow-up studies from 4 weeks onwards, then the patient needs to have a dual phase study. The reason is your arterial phase study is for giving you an arterial map and check there's no pseudoaneurysms, and the interventional team find it really useful. And then your portal venous phase is for checking for any bleeding from pseudoaneurysm, checking for pancreatic parenchymal enhancement, defining your pseudocysts, looking at venous enhancement to check that there's no splenic or superior mesenteric or portal vein thrombosis, and also to evaluate the other abdominal structures. So it's really important in that setting to use a dual phase contrast regimen. Okay, so moving on to thinking about things which are now beyond just a single portal venous phase. 75-year-old female, sudden onset severe abdominal pain, hypotensive and tachycardic. Now there could be lots of different things going on here, some kind of perforation, but often they'll ask you and they'll put it to you that we think this might be bowel ischemia. So then you have to figure out, well, how do you go in at the outset with your protocol, assuming the patient can receive intravenous contrast. So in this one, we elected to do a dual phase study. So we've got arterial and portal venous phase studies. And this really helps because on the arterial phase study, what you can see is you start from the top. We've got the aorta, we've got the celiac axis, and then we've got the SMA here. And I'm going to keep on the arm the SMA, and then all of a sudden it stops. Okay, so there is a huge filling defect of the SMA, and then beyond that level, it's not filling at all. Now, you could see that on the portal venous phase study, but it's just a lot easier to pick out on the arterial phase study. And then there are other features here of arterial small bowel ischemia, which is distension of the small bowel. And this is a really typical finding where you get paper thin small bowel. So the bowel wall becomes extremely thinned. There is very little enhancement of the bowel wall, which you can appreciate on either the arterial or portal venous phase. And there's quite a long length of the small bowel, which is distended. Because it's a fairly proximal obstruction to the vessel, so you'd expect there to be quite a long length of small bowel involved. However, our small bowel or mesenteric ischemia protocol is actually, I think, a triple phase protocol, which includes a non-contrast. And the reason is because of this case. So let's look at this one. 8-year-old female, similar abdominal pain, hypotension, tachycardia, acute renal impairment. So in this particular patient, for some reason, they decided to forget about not give contrast, just do a non-contrast study, which is not necessarily the correct thing. With acute renal impairment, with no contrast allergy, if it's a life-saving situation, I would advocate that you give contrast. But the point I want to make here is, what do you see on a non-contrast CT with bowel ischemia? Well, in the process of bowel ischemia, one of the events along the pathophysiological cascade is development of mural leakiness and mural hemorrhage. Okay, and so you get blood within the wall of the bowel, and that manifests on imaging as thickening of the bowel wall, but with high density. And you can't appreciate that once you've given contrast. So on a non-contrast CT, what you see is this person's got quite a long length of distended small bowel, very congested and streaky, edematous-looking mesentery. And then if you look at the bowel wall here is more dense than it should be. And this will take you some time to appreciate and get your eye in for. But over here, there is more density in this bowel wall than is expected for a normal non-contrast CT. So all of that in combination, the distension, the mesenteric congestion, the bowel wall thickening and density, and the clinical presentation is very strongly suggestive of ischemia, and this was confirmed then at surgery. But ideally, we do a triple phase CT, which gives us all the information that we need to be able to make the diagnosis, bearing in mind that you're doing this prospectively, okay? So you can't go back and add any contrast phases afterwards. And when you're dealing with a very heterogeneous population that's coming into you, it's better to start with the best protocol, accepting for a lot of patients it'll be the wrong one afterwards, and it ended up just being a duodenal perforation. You didn't need all the phases, but it's more difficult to then go back and then do the whole thing again. Right, so the next one, again, we're thinking about multi-phase CT now, okay? 55-year-old female, so trauma, fell, hit her flank on a hard edge, attended 12 hours later with hematuria and worsening pain. So we've got this study which is split into two separate portions. But in your practice, I want you to try and do this in one, okay? So this is again a triple phase CT. So with the ischemia one, we're doing non-contrast, arterial, portovenous. Now with trauma, we typically do not do a non-contrast CT. The general trauma protocol that we have is an arterial phase, chest, abdomen, pelvis, followed by a portovenous phase, abdomen and pelvis. So the reason for that is you want the full arterial map of the body, and then you want the portovenous phase where you're concerned that there might be extravasation of contrast and for enhancement of the organs and the mesentery and the bowel for signs of trauma to those structures, okay? So with this patient, let's just focus on the main abnormality. The left kidney is normal, so we'll put that to one side. The right kidney is grossly abnormal. We've got fluid and high density distending the renal pelvis and the pelvic ileocecal kind of structures here in the hilum of the kidney. We've got fat stranding all the way around the kidney, like a rim of fat stranding, but also this high density, which is more than fat stranding. So that could be blood kind of encasing and enveloping the right kidney. This is all on the arterial phase study. Something else you look at is the renal artery. Check that there's no renal avulsion. Okay, so if there's a motor vehicle accident, deceleration forces, then you can get renal artery avulsion. And in that case, the renal parenchyma would not be enhancing at all. And then we go to the portovenous phase where we're going to look at the renal vein, really importantly. Check that there's no avulsion or thrombus there. Look at the enhancement of the parenchyma, check that there's no areas of hypoenhancement. This is where renal lacerations will become apparent because you'll see linear or jagged areas where there is no contrast enhancement, and we see that here. There's a line running through here. So there's a renal, full thickness renal parenchymal laceration. So we know a lot already just from these two phases. But there is one thing that we don't know. We don't know whether or not there is a rupture of the pelvic ileocecal system and a leak of urine. And what you need to do is a further phase with the same load of contrast on board, but just a later acquisition. So that's what happened. This patient was brought back an hour later, and now you see this is normal handling of the contrast by the left kidney. So it's in the pelvic ileocecal system and then down the left ureter. But on the right side, there's a couple of interesting things here. One is we've got this filling defect here within the right renal pelvis. So there's a blood clot. So blood is clotting within the renal pelvis, but also we've got this, the double passage here, which indicates that there is contrast within the normal right ureter, which is this bit posterolaterally, but then we've also got contrast here anteromedially, which is within, which is actually leaking. So this is tracking up here. So there's a rupture of this calyx, and then this contrast, which is leaking out. Okay, so there is a contained urinary leak in this patient, which doesn't then carry on down here. It's just kind of contained to this upper retroperitoneal region, and would explain why there's so much fat stranding and fluid around the kidney, because there's a combination of blood, edema, and leaking urine as well. So if there is any suspicion of renal trauma, you need to do a multi-phase study, which includes some form of delayed phase to allow for the contrast to be handled by the kidneys and then leak out of the pelvic ileal system if that's what's going on. Okay, so we've covered lots of different uses of contrast administered intravenously. So we've done non-contrast CT, then we talk about portal venous phase, and then dual and triple phase applications. And those are really the main ones that you need to get started with. Now let's talk about contrast via a different route, which is oral contrast. And you will be asked to look at these as well when you're protocoling. And we use oral contrast for CT in some very specific situations, not with general, not with all types of abdominal CT. We use gastrografin and we dilute it to 5% because at that concentration, of course, it's water-soluble gastrografin, but at that concentration, it's the appropriate density for CT, so it doesn't give artifact. It's quite an easy calculation for the radiographers to produce a 5% dilution, and it's non-irritant to the peritoneal surfaces. So if it does leak, then it's not going to cause peritonitis like, for example, barium would. And there are 4 specific scenarios that you need to be familiar with, which are based on the type, based on the specific part of the anatomy that you want to assess. Okay, so we've divided up into 4 sections. So the first one is for the esophagus. So this is a 65-year-old male who's had an esophagectomy, and this is for assessing for a leak from gastric pull-up. So whilst they've had an esophagectomy, the part of the anatomy that we want to assess is the most proximal part of the GI tract. So we use the esophagus protocol. So that person's had a gastric pull-up, the stomach's been pulled up into the chest to replace the esophagus. So this protocol still applies. So in this protocol, we give 100 milliliters of 5% gastrografin on the table. So the patient drinks it, then they lie down, and then we do the scan so that it kind of hangs around in that region as much as possible, and we scan immediately afterwards. So this is an example of what that kind of scan looks like. This patient's had a pull-up and they're actually known to have a leak. This is a follow-up study. Okay, so I've not shown you some of the other previous images before this. So we've got the trachea, and then behind that, this is the pull-up, and the density within it is the contrast. And as we scroll down, then from the back here, there is a leak, and this is a tube that's running out from outside of the body through the hole that they've got. So they've got a pretty wide open leak from the posterior wall of the pull-up into the lumen. Okay, and the contrast in this follow-up confirms for us that there is an ongoing leak, that this is not sealed up. The contrast has come out of the lumen of the pull-up into this collection, which is tracking all the way alongside the drain to where the drain comes out of the patient's body. So this is a pretty obvious and gross example. Most of the time it will be slightly more difficult to appreciate. But the principle is what I want to convey to you, which is if it's an esophageal leak or a leak to do with a gastric pull-up, i.e. an esophageal replacement, then use this particular protocol. So the next protocol is for the stomach. So we've got a 45-year-old female who's had a sleeve gastrectomy for weight loss a week earlier, and now she's got pain after eating a light meal, tenderness and raised inflammatory markers. So they're wondering whether or not there's been a leak, perhaps from the staple line that you get when they make a sleeve gastrectomy. So if you're interrogating the stomach, or an esophagojejunostomy, so where the stomach has been removed and the jejunum has been plumbed onto the esophagus, or the duodenum, so essentially the upper part of the abdominal portion of the GI tract, then you give 200 ml of 5% gastrografin 5 minutes before the scan. So it's a slightly greater volume, slightly longer time point. So here is what we see. This is the first, this is the CT that the patient had. And we've got, if you've not seen a sleeve gastrectomy before, this is what you see. If we've got esophagus here, then this is the stomach, and the staple line here is going to run along this curve, and the stomach is now much smaller in volume than it used to be, so it's just like a thin banana shaped tube. And up here, just under the left hemidiaphragm, we've got this collection which has got gas and fluid. Now the density of this fluid is greater than just normal fluid. This is because this fluid is mixed with oral contrast that the patient has drunk and is leaked out from the lumen alongside the top end of the staple line into this collection. So this confirms that there is a leak and they'll need to go in and repair this. There's also a bit of pneumoperitoneum here, but that could be normal depending on whether or not this is a complex operation, and that can sometimes be seen. The other thing just to be aware of is this here, you might think, oh, there's a small fluid collection as well alongside the staple line, which is what I thought. In fact, they said, no, this is some sort of glue material that they used to make sure that there was satisfactory closure achieved at this staple line. Okay, so the third protocol is to do with the small bowel. So this is a 70-year-old male who's had this long-standing midline wound discharge after several laparotomies and different bowel procedures many years earlier. And they're wondering whether or not he's got an enterocutaneous fistula to account for this wound discharge that he has. So for the small bowel, we give quite a large volume. We aim for a large volume anyway. How much of that they can drink varies. 1,000 mils of 5% gastrographin 60 minutes before the scan to allow the small bowel to fill up and distend with the contrast. So this patient first had a normal CT, and you can see that they've got a very abnormal anterior abdominal wall with some tissue missing. We've got small bowel loops which lie very close to the abdominal wall, but on this kind of CT you've got no way of telling whether or not there's an enterocutaneous fistula. All you can say is that there are bowel loops that lie close to the anterior abdominal wall. So when that's repeated with oral contrast, so you can see that there's contrast in the stomach within small bowel loops all the way down here. First thing is that there is contrast in the bag that overlies the wound. So you know that that's a sign of a positive test that there is a fistula, because contrast has leaked out from what they've drunk into this wound bag. And the next thing is you can identify specifically exactly which bit of bowel that's leaking from, and it's here. So there's a bit of bowel, small bowel coming in here, and it comes here and it heads out into there. So you can identify exactly which part of the small bowel is feeding the fistula. So you can confirm there is a fistula and localize exactly where it's coming from. And then finally, for a situation where someone's got a Roux-en-Y gastric bypass, there are two different anastomoses that you want to interrogate. So let's look at this example. Someone who's had a gastrectomy and an esophagojejuno anastomosis. They've got a feeding jejunostomy, raised inflammatory markers. Now, this is the kind of anatomy that I'm talking about. So if someone's had a bypass, there'll be two anastomoses. You've got the more proximal one here, which is an esophagojejuno anastomosis, or an anastomosis between a bit of a pouch of the stomach and the jejunum. And then there'll be this second anastomosis between two different parts of the jejunum, so a jejuno-jejunal anastomosis. In terms of nomenclature, this is known as the alimentary limb, okay? So because the food passes down that bit. The defunctioned stomach and duodenum and jejunum is left in because the biliary and pancreatic juices drain into that and then down into the rest of the small bowel. So this is known as the biliopancreatic limb. And then everything onwards from the second anastomosis is known as the common channel. So this is where digestion can then take place because you've got all those digestive juices. So for this, because we're interrogating two different anastomoses, potentially, we give a hybrid protocol. You give 100 mils of 5%, well, you start with 300 mils of 5% gastrographin 30 minutes before the scan. And the idea of that is it will allow us to evaluate this distal anastomosis. And then you give 100 mils on the table for this more proximal anastomosis. So this is an interesting scan. So the first one, what we see is the contrast fills the esophagus, comes down here. We've got an esophagojejunostomy, which fills nicely with no leak at all. So we're happy there's no leak. There's a couple of other interesting findings that you'll come across when you look at scans after GI surgery. First is this low density area here in the spleen, and this is basically a retractor injury where they've been doing the surgery, and often you get these areas of hematoma involving the surface of the spleen or the liver. And then the second thing is, look at this florid pneumatosis of the small bowel. Okay, there's a lot of small bowel here with gas in the bowel wall. Now, the first time you see that, you'll be concerned. You think, oh, this person's developed small bowel ischemia as a complication of their surgery, and now they've developed small bowel necrosis and infarction. But in fact, this is a known complication of a feeding jejunostomy. So here, the feeding jejunostomy is coming in through the abdominal wall. You can see this tube here is running along the bowel wall. And when they first start feeding through feeding jejunostomy, sometimes you can get this kind of air that's ripping through the bowel wall for quite a long length and causing this appearance of pneumatosis, which is quite alarming. But all they need to do is stop the feed and resite the jejunostomy, and this will resolve. So this is not in this case, this is not because of small bowel infarction. So anyway, that patient did have that resited, but they actually got worse. And now this is day 15 following surgery. They're asking the same question, whether there's a leak. So we've again given the contrast. You can see it in the esophagus, here coming down below the diaphragm, but this time it is leaking out. So it's leaking out here into this collection here, just deep to the left hemidiaphragm. So you can see here that there's contrast mixed with gas. Okay, the small bowel has now returned to normal appearance. If we look at that in the coronal view, you can see that coming out from here, there is a deficiency, a defect near the anastomosis, leak of contrast and air. So this confirms that there is definitely something that they need to go in and fix. There is now an abscess forming in the left subphrenic space. Okay, so those are all different types of oral contrast regimens that we can look for, and you'll find all of those listed in the drop-down menus when you're protocoling in CRIS. So the next one is a 20-year-old male, another trauma scan. He's fallen from height. And there's lots of different studies to walk through with this one. So this is one of the x-rays he had when he came in. He's got a catheter in, and he's got some fractures of the pubic symphysis, which are really hard to see here because they're very kind of minimally displaced. You'd have to window this on PACS to see, but there is a fracture line running across the upper and lower part here of this pubic symphysis. But there was no widening of the sacroiliac joints that was appreciated, and nothing else really. He then had an ultrasound, and what was noticed was that there was free fluid in the upper abdomen. Okay, so at this stage, all it had was the plain films catheterized, and then he had an ultrasound of his abdomen, and he's got plain free fluid. So that's concerning. He then had a plain CT for planning of fixing of his pelvic fractures. So we can see that the catheter is in, there's the balloon within the bladder, but there is a large volume of fat stranding in the anterior abdominal wall, and there's lots of free fluid around the bladder in the lower part of the abdomen and in the pelvis, and he's got quite a lot of free fluid coming up to the upper part of his abdomen. Okay, but this is still just a fracture planning orthopedic CT because you can tell that we've got bone windows here. He then finally gets reviewed in a clinical meeting where it's pointed out that he's got features of some kind of bad intra-abdominal injury with all the free fluid. So he has a contrast CT, an arterial phase, where he's got some free fluid in his upper abdomen, but his solid organs all seem to enhance normally on the arterial phase. But on the portal venous phase, what we see is that there's a lot of free fluid and there's air here in the pelvis anterior to the urinary bladder. And his urinary bladder's got a thick wall. The balloon is still inside the Foley catheter balloon. So I think it was finally suggested to them that you should be thinking about a bladder injury here because that's what really naturally fits with his story. The fact he's got pelvic bone injury, he's got a lot of free fluid, and he's got no solid upper abdominal injury. So we did a CT cystogram. So dilute contrast is instilled into the bladder via the urinary catheter, and then lo and behold, straight away you can see there is a hole in the anterior wall of the urinary bladder, and he's got an extraperitoneal bladder rupture with all this contrast leaking out into these extraperitoneal tissues around his urinary bladder, not into the peritoneal space itself. You can tell that because this is just confined to this region here. There's no contrast entering into the peritoneal spaces. Okay, so it's an extraperitoneal bladder rupture. CT cystogram is the way to do it. Make sure that the clinicians have got a catheter in the urinary bladder. You just inject some dilute contrast into the urinary bladder until the patient's bladder is distended and they're slightly uncomfortable. You've got to clamp the catheter and then acquire a non-contrast CT, and that will tell you straight away what's going on. Now here is another example, again trauma, motor vehicle accident, and on this occasion what we see on this portovenous phase is again the solid abdominal viscera all look normal, and we've got contrast within the bladder here, but it hasn't really filled the bladder. So this is I'm not sure whether they've injected this via the urinary catheter or whether this has been excreted via the kidneys, but I think it's probably via the catheter, but it's not an adequate amount to fill the bladder. There is fluid and some thickening around the urinary bladder, and there's a bit of mesenteric free fluid. But they then acquired a delayed phase, which has allowed the contrast that was excreted via the kidneys to enter into the bladder, as well as the contrast that was injected into the bladder. And now we see that there is contrast here, so in the peritoneal space, you see on this left side, and then adjacent to bowel loops. Okay, so not a huge volume of contrast, but that tells you that there is a bladder leak, and this is an intraperitoneal bladder rupture. So on this occasion, what's happened is the bladder has ruptured superiorly into the peritoneal space. Now, very broadly speaking, the ones that require operative management are these ones, the intraperitoneal bladder ruptures. The other ones, the extraperitoneal ruptures, are treated usually with a conservative pathway with catheterization. Okay, and then finally, the final kind of route of administration of contrast is rectally or anally. And this is the one we do least often, but here's an example if you ever need to do it. So as an 80-year-old male who's had a recent sigmoid colectomy, he's got raised inflammatory markers, acute kidney injury, so they're wondering whether he's got an anastomotic leak. So what we did was, it's a non-contrast, meaning non-intravenous contrast CT, but with dilute contrast administered via a Foley catheter, which has been placed into the lower part of the rectum via the anal canal. And then same with the cystogram, you instill that contrast, and then you just spigot it or clamp it and then do a non-contrast CT. So we see the contrast here within the lumen of the rectum. There's the tube. This is sort of fecal matter that's within the rectum. We follow this up, and then come to here. This is the sigmoid, and this is the sigmoid. So we can follow the lumen of the bowel, and they've done a primary anastomosis. But just above this bit of bowel, this is extraluminal contrast within an air and fluid containing collection. Okay, this is not within a loop of bowel. So this means that there is definitely a perforation or a leak, from the anastomosis, which you can't really tell exactly where it is, but there's no way that contrast could have got there unless there was a leak from the anastomosis. There's no other way this could have reached this area. So it helps to confirm this isn't just a post-operative fluid collection. This is because of an anastomotic leak. Okay, so that's everything I want to talk to you about protocoling abdominal CT. So once again, remember, it's all about whether or not you're going to give contrast and then the timing of the contrast. There's a couple of scenarios where non-contrast CT is useful. Renal colic assessment is the main one, but also as part of a multi-phase protocol for bowel ischemia. Most acute abdominal diseases require just a single portovenous phase, such as your various itises, diverticulitis, appendicitis, and so forth. A few scenarios for multi-phase CT. So the follow-up of acute pancreatitis, arterial and venous phase, to make sure you don't miss a pseudoaneurysm, as well as all the other complications such as venous thrombosis and looking at your pseudocysts and parenchymal enhancement. Trauma, multi-phase standard, arterial and venous, but with renal trauma, remember to also consider a delayed phase to look for leak from the collecting system. And then we talk about various oral contrast protocols depending on the part of the anatomy that you're interrogating, whether it's thoracic, so esophageal or gastric pull-up, proximal upper abdominal, so stomach, esophagojejunostomy, duodenum, small bowel, or whether it's a hybrid protocol because the patient's got a gastric bypass. And then administering contrast via the bladder, so a CT cystogram will help you differentiate different types of bladder rupture. And then a rectal contrast protocol will help you look for anastomotic leak. Okay, thank you.